All right. I think we're good to start. I don't see anybody else waiting to come in. So I'll introduce myself. I'm Jessica. I'm the president of the Alberta Horse Trolls Association and also communications chair. We are really happy to be doing another online seminar, and we're happy to sorry. Yeah. Okay. Sorry. We're really happy to have Alanna Bowie here, who is doing a session on human trauma in equestrian sports. And we'd like to thank Kathleen Zeeler for organizing this webinar. She is our athlete development chair, and we're very thankful for all the work she does behind the scenes. And I think everybody is in now, so I guess, Alanna, I'll turn it over to you, and you can introduce yourself and share your screen, and we can get started.
Sounds good. So as Jessica mentioned, I'm Alanna. It's nice to virtually meet everyone. I see some familiar names. And I am now working as an emerge doc, and so I'm trying to combine some knowledge from eventing and some knowledge from the emergency setting. Just start screen sharing here. Oh. Okay. Okay. Can I get a thumbs up or just some sort of indication that people are able to see my PowerPoint here?
Yep, you're good.
Yeah, sounds good. And then I was chatting with Jessica before we let people in from the waiting room. I'm sometimes very bad at using medical words when I'm trying to explain things. So if there are questions that come up throughout the presentation, please raise your hand or mention something in the chat, and I am more than happy to pause throughout. I will probably ask for some responses throughout the presentation as well and see what the group thinks. But we are talking about blunt trauma and equestrian sport for the humans, not the horses. And I just want to start off with a land acknowledgement. And I recognize that Red Deer, where I am speaking to you from, serves and occupies Treaty 6 and 7 land, the traditional territory of the Blackfoot, Tsuut'ina, and Stoney Nakoda peoples, traditional Métis, Cree, and Saulteaux territory. In terms of disclosures, I have no financial disclosures. I am paid by Alberta Health for my work in the emergency department, and I have a salary position through the University of Alberta. I did use the University of Alberta library for quite a few of the studies that we'll go through during this presentation. And then I'm also a member of the high performance team for the AHTA. And this is my fabulous horse, Oshi, and photo credit affiliate photography. And then for reasons for us doing this talk, I just loved this quote. This is from one of the studies that we will briefly talk about, but I love the description. And the authors of the study said, despite being viewed as a relatively safe and bucolic pastime, equestrian activities are among the most accident-prone, sustaining more injuries per hour than American football, motorcycling, skiing, and car racing, with a rate of approximately, essentially 0.5 hospital admissions per 1,000 hours, or 1 hospital admission per 2,000 hours of riding, which is high. I was surprised at how high that was. And then the meme here with the horsing, I should have told you I was about to stop, because we often don't get much forewarning. And then for tonight, my hopes are to cover an approach to a down rider, and that can either be from a fall, like where the horse and rider falls, or if the rider just has a fall off the horse. And then we'll talk kind of probably as much as I can about concussion guidelines and initial assessment and returning to riding. And then we'll briefly talk about review of the literature on safety equipment in equestrian sport. So this is my diagram that I did, which is why it's not great. So if you have a, okay, so if you have a rider down, my thought would be that the first thing that we should really approach, or the first thing that we should really assess when we're approaching a fallen rider would be if there is a pulse and if they are breathing normally. Later in the video, we'll talk about people can be dead and still have strange kind of, we call it agonal breathing, but it can look like gasping breathing or sometimes look even like fast breathing. And so if you're not seeing normal breathing, it's worthwhile to check a pulse and see if we should be proceeding down this pathway. So if there is no pulse and they are not breathing normally, then we need to start CPR. And if you are alone, like let's say if this is a clinic situation and not a competition, then ideally you want one person to be calling 911 and one person to be getting an AED. For anyone that might not know what an AED is, there's a short video and they're so important. And I really think if there's one thing that people take away from this talk, it would be how and when to use an AED. And then I have put in here to be mindful of C-spine. And so the C-spine, as we're going to get to, is just the neck. And then starting CPR, I'm hoping that at least some people will have some BLS training, but really we're looking for chest compressions, whether or not you feel comfortable with rescue breaths. I think there's some debate about that. And in the adult literature, really most of the time, death is caused from a heart cause, and so breathing is less important. In children, it's a little bit different, but hopefully you won't have to think about this with children. Okay. And so this is just a diagram so that everyone knows what I'm talking about when I say C-spine. For the duration of the talk, I'll probably use that term. And then as you can see on this diagram of the human skeleton, the cervical spine is the least protected and has a lot of mobility, and so is quite injury prone. And that's where if we have a serious injury to the spine, especially at a high level, like in the neck, then we can see paralysis, which of course is devastating. Okay, and then I'm going to try this, just with saying that sometimes videos don't work super well on Zoom, but I really think that, again, this is important.
Stuck poop can make thin women feel plus sized. To have the
We're gonna
best
watch
poop
an ad
of your life,
first.
you don't need fiber. You
An AED is a life-saving device that can give your heart an electric shock when it has stopped in a cardiac arrest. AED is short for Automated External Defibrillator. An AED can be used on adults and children over 1 year old. Using an AED in crucial.
Okay. I'll maybe have everyone take a look at that later. Jess and I had done a test run and it had worked a little bit better. But so essentially with AEDs, if you have someone that doesn't have a pulse and is not breathing, I know that the AHTA has at least one AED, and so yes, go get it immediately. And then it is definitely well known in medicine that the two things that are most effective at bringing someone back from death are defibrillation, so using this AED, and CPR. So it's not like ICU care, and it's not anything fancy that we do in hospital. It's these two things. And for an AED, there are stickers if you've never seen one, and it will tell you where to put the pads on a chest. And so essentially you want the two pads to be on either side of the heart, and you want the electrical current to go through the heart. So one pad goes on the right side of the top of the chest, and the other one goes on the left side, kind of underneath the armpit. You don't want it too far forward because the heart has to sit in the middle. And then for anyone that is a science nerd, I just included some number needed to treat. And so in medicine, we often talk about number needed to treat to prevent an illness or to treat someone for a medical condition. And for using an AED correctly and in a timely manner, if you treat 2.5 people, it will save one person's life. And then in comparison, our medications in the hospital would be you'd have to treat at best 7 people to have one person survive, but it may be closer to like infinity. So really CPR and defibrillation are the most important. And then I had gotten a question, which I think is a very valid question, about how to remove a helmet after someone has fallen. And the first thing I would say is to be super careful about if you need to remove the helmet. So if there's no concerns with breathing and the person's head and neck are in a neutral position with the helmet on, I would say that you won't necessarily have to remove the helmet. It's super reasonable to unclip the helmet if that's easy access. But if for some reason you do need to remove the helmet, there's 2 techniques. This, we can send out these links, but this YouTube video goes through for a football helmet. And so obviously it has, the cage on the front, which is not something that we need to worry about. But in the video, they have one person at it would be like the person's head standing behind the person, and they keep both their hands, would be much easier with the video, but keep both their hands on either side of the ears and maintain stabilization. And then a second person gradually kind of pivots the helmet off. That is less intuitive to me. The way that I was taught was to have one person from the side, kneel probably, with their one hand on the chin or the mandible, and then one hand on the base of the skull, just above the neck, and then hold that firmly. And then a second person that's standing behind the person again, so it would be at the head, would slowly wiggle the helmet off, and then the person that had removed the helmet then takes over maintaining stabilization and keeping the head still. And then there's kind of 2 ways to do that, and again, an intuitive way to me is to put if you're behind the person, is to cuff the person's shoulders on both sides and then have your forearms lining up against the head. Does that make sense to everyone? Hopefully. I'll get thumbs up or questions if anyone has any. Oh, here's a picture. So this is what I'm trying to show. This is the technique that I'm more comfortable with. And this is probably what I would use. And then here, this obviously is a football player. And so they have quite a bit of padding to their shoulders. And I think in theory, this could probably happen in equestrian sport as well, depending on if someone's wearing an air vest and how much their shoulders are lifted. So if someone's shoulders are lifted off the ground and their head is kind of tipped back, that's not a neutral spine position, and I would say not safe. So if you remove the helmet and then it looks like there's going to be a gap between the back of the person's head and the ground, it would be worthwhile trying to put clothing gently underneath that person's head, or if there's another rider whose vest you could tuck under there, really anything to keep everything in line until paramedics can arrive. Okay, so coming back to our down rider, let's say now we have pulse, we have breathing, then the first thing I would assess is if they are awake and able to communicate. And then if they are, then the next thing I want to know is if they have pain. So if they have pain, like even feeling funny to their neck, then I would say they shouldn't move, and EMS should be called, and they stay in that position until EMS does arrive. Or if they have numbness or tingling to their extremities, or if they've lost control of bowel or bladder, that can all be a sign of a spinal cord injury, and that person should not move. Okay, so these would be my kind of take-home personal red flags for when to call an ambulance. And so if someone has chest pain or shortness of breath, then we'd worry about chest trauma and maybe broken ribs, which can cause a popped lung. Or again, if they have numbness or tingling to arms or legs, if they have neck or back pain, I said immediate or severe, which would be more concerning. But even mild neck pain, I would not feel comfortable just clearing and saying that they were fine to return to riding. Again, loss of control of bowel and bladder, unable to move arms or legs. And if they've had a period of loss of consciousness, then I think that they should be assessed in an emergency department, even if they are now awake and talking. These are great videos, and I thought just were good for depicting possible injuries in riding. And then the third one on this slide looks awful from a neck perspective. This third one is not a horse related YouTube clip. The first one was a rider that was competing and then comes off and like very clearly looks okay. And so in that case, if the person has no neck pain, no headache, and is feeling fine, they've got no amnesia, they likely do not require further assessment in an emergency department. The second person, again, gets up fine and looks overall well, but I would say is at high risk for a concussion because of the mechanism. So I'll let you guys watch that after the presentation. And then when I say it's high risk for concussion because of the mechanism, it looks like on the way down, the rider had quite a significant whiplash type injury. And so any acceleration, deceleration injuries really increase your risk for a concussion, even if there's not a lot of trauma to the head. And then this person, I would say, watch at your own risk. It is a gnarly video. And then I think there is a lot of misinformation about concussions, probably both in the medical world and certainly outside of the medical world. And so a concussion is considered a mild traumatic brain injury, and moderate or severe traumatic brain injury would mean something that needs neurosurgery. So if there was a bleed in the brain, or if there is altered level of consciousness for a prolonged period. So if someone isn't able to respond to questions appropriately or isn't waking up, those would all be signs of moderate or severe brain injury. And of course, definitely need to go to emerge. There is no CT findings or MRI findings with a concussion. And so if, like, as a parent, for example, or as a patient, if you're worried about a concussion, imaging and blood work don't help. It's a clinical diagnosis, and we'll try to talk a bit about that as well. And then for what is actually going on, so I'd say it's still largely theoretical, but it seems like there is, I said, metabolic insults and electrochemical imbalances. So everything in the body is conducted through kind of salts and ion channels, and it seems like that gets dysregulated during a concussion. And a concussion can be from a direct blow to the head, or as I mentioned, can be an acceleration, deceleration injury. So you don't need to have an actual fall necessarily, or you don't have to hit your head to have concussive symptoms. And then how to identify a concussion. I am sure that this is such a perplexing and frankly probably horrible topic for coaches in particular. There's no reliable test to either rule in or rule out a concussion. So again, there's no imaging and no lab test that can definitively diagnose a concussion, but the hallmark findings for a concussion would be some type of event, let's say a fall in this case, and then the person has amnesia surrounding the event, and that can either be they have gaps in their memory from leading up to the fall. It's very common to not remember the fall itself, and then sometimes won't remember things that happened after the fall, or there'll be a gap in their memory then as well. And for signs and symptoms, I'm wondering if we can have people write in the chat, just so I know that someone's listening, about signs and symptoms they might expect to see for a concussion. And Jess, you might have to help me out because I can't see the chat if people are responding. Yeah, perfect.
Do you see?
Okay.
Yeah, confusion, dizziness, nausea, headache, lightheaded.
Yes, absolutely.
Yeah, difficulty
Okay.
concentrating, brain fog, light sounds, sensitivity. Yeah.
Yeah, absolutely. Those are all good. Okay, and so there was a new international concussion guideline that came out, I think in 2023, if I remember correctly. Sorry, I'd have to look at that just to make sure that that's the correct year. And so this is, I would say, generally one of the tools that's recommended for on-scene assessment. I did get a question on the Google Drive about what I would recommend for concussion assessments at on scene. And I think this is probably, if you're not a healthcare provider, I think this would be a reasonable one. And I do like that they have the red flags and reasons to call an ambulance, which is, I would say, like the same. I agree with all of those bullet points there. And then for physical symptoms, so concussions are challenging as well because we can have a lot of these symptoms from other things. Like if you have a virus, for example, you can get a headache and nausea and feel drowsy. But if you have, like if you previously felt fine and then you have some type of trauma or whiplash injury and then you get these symptoms, that to me is a concussion until proven otherwise. And proven otherwise is not going to happen that day. It's going to be down the road. So if you have any of these symptoms, you should stop riding and go home and rest. And then I took a look at Equine Canada's return to sport. And again, I would say that this is in line with general recommendations from international concussion guidelines. And then the website Parachute in the top right there has a lot of good information. I think if you're looking for some information about concussion, I think that's a good resource, and it is all free, open access. And really after a concussion happens, It is definitely recommended to take 24 to 48 hours of rest. I typically recommend 48 hours just because I think it's easy to have patients walk away with one specific number. And then when we say rest, we really do mean rest, like not a gentle ride. I mean, like mostly hanging out at home. There is some evidence that maybe very light activity, if you feel well enough in the first 48 hours, might be reasonable. We want you to minimize screen time as much as possible, and then you should not be working or going to school. And then from there, so if you have symptom resolution over that 48 hours, then you can go on to light activity. So that would be, again, things like walking. They say stationary biking. I typically don't recommend that, but I typically just tell my patients walking specifically. And then things like reading would be reasonable, and for short time periods to make sure that you're not getting symptoms. So again, on day 3, I will often talk to patients about half an hour of each. If you have no symptoms following that and you're still feeling well, then you can progress to step 3. And they do on the Equine Canada website, they do go through that. And that would be the same if you have family members or yourself gets a concussion from another sport. It's the same thing. You start off with things like walking, and then can progress to running or dry land. You do not go back to that sport until you have seen a doctor and been cleared by a doctor. And another question that I often get is how long to expect to fully recover from a concussion. And on average, it is about 4 weeks. So it is not like a couple days of rest and then you're back competing the next weekend. It's not typically how things go. And then I would say there's 2 reasons to rest after a concussion. And the biggest one would be second impact syndrome. So second impact syndrome is rare. And what can happen is when people are recovering from one concussion and they still are in the symptomatic period, if you get a second concussion, it can make things significantly worse. And it seems like there's more dysregulation in the brain, there's swelling, and can cause death. So very serious. Like I said, it is rare, but because it's such a high risk diagnosis, we really recommend full recovery. And I always recommend that patients see a doctor before returning to full sport. I recognize that that's super tricky right now with lack of family doctors, but I guess we can try and talk about that after. That's a whole other conversation. And then the second reason to rest after a concussion is it's pretty common to be somewhat unbalanced and definitely not at your baseline following a concussion. And so then you are likely at higher risk for more falls or more trauma. And the more concussions that you get, you are more likely to have chronic traumatic encephalopathy. And for anyone that's seen the movie Concussion, I can't remember who stars in that. It's maybe Will Smith. It's really good. I did like it, I promise, even though I can't remember who the star actor was. And that's what they're talking about. It's about football players, and a lot of them have these horrible symptoms. And chronic traumatic encephalopathy is like Alzheimer's or dementia, where we can see changes in memory, changes in personality, and very debilitating. So definitely something, again, that we would want to avoid. Okay. Should we wear a helmet? I feel like that is a good place to start when talking about concussions and safety equipment. So I would say intuitively wearing a concussion makes sense. And then when I was trying to do some research for equipment for this talk, it looks like the British Pony Club made helmets mandatory, I think in 1990. And anecdotally, they did see a decrease in skull fractures and traumatic brain injuries when it was mandatory for people to wear helmets. So I would say anecdotally from that and intuitively, it does make sense to wear a helmet. And then this study was looking at 142 people. I'm just gonna pull this up. And I believe this was from the States, if I remember correctly. And so they looked at essentially people that were wearing helmets versus not wearing helmets and the risk of traumatic brain injury, whether that was mild traumatic brain injury, like a concussion, or if there was a bleed, such as a subdural or which is a type of brain bleed. Sorry, it's very medical. And then looking at this, you can see that there were a number of factors where there was a signal, and in some cases, statistical difference for those wearing a helmet versus no helmet. So when I say statistical difference, that's looking at the p-value. And the p-value for all of the studies that we're going to talk about is a measure of something being possibly due to chance. And so we think that if a p-value is less than 0.05, then it is unlikely that the difference in those outcomes were due to chance. So for injury severity score, traumatic brain injury, and ICU admission, that was deemed statistically significant. I would say that there's still a signal for helmet safety in the other metrics, in terms of like the Glasgow Coma score is something that we look at, and it's a measurement of alertness when people come into the emerge. Yeah. And then craniotomy is a type of surgery if people have a bleed, basically. Is there anything else? Yeah, and I guess for limitations for this study, I thought that this was a very sick cohort. So I think a lot of these studies were done at trauma centers, so not smaller rural emergency departments, and also not the people that, of course, chose not to go into the emergency department where they felt that they were safe at home without being seen by a doctor. So of this group, 97% required hospital admission, which is way higher than what we typically see for falls, for example. But from the study, I would say wear a helmet.
We have a question in the chat.
Sure.
Lisa asked, does a MIPS helmet make a difference? And I don't know if you're gonna touch on this later, which would be fine, but
yeah. We'll chat about that for sure.
okay.
Okay, and then for this one, yeah, so this was interesting. Again, a very sick cohort. So this was a group that had, again, from the Midwestern, Northwestern United States. And these patients had presented to a trauma center. It sounds like their catchment area was largely like quite rural. And they had mentioned that Western riders don't often wear helmets, which is certainly true. I can say that from personal experience with my friends that ride Western. And they saw less of a benefit, they said, in terms of traumatic brain injury, but in terms of skull fracture, open wounds, helmets did seem to offer a benefit. And then although it's not statistically significant, I would still say that there is a suggestion of decreased risk of concussion, for example, in the no helmet versus helmet group. So 25% of people that wore a helmet got a concussion, and 33% of those that didn't wear a helmet got a concussion. So very small study, limited by selection bias. So it's only people that went to this trauma center. So again, a very sick group of people. And then they also had commented that it's not mandatory for the doctors to write if a helmet was used or not. And so there could be some crossover. This might not be 100% accurate. and the type of helmet used and the condition of the helmet was not known. So it's possible that for people wearing helmets, they could be 30 years old and like broken and busted in. It's just not known for this study. Okay, that's exactly what I just talked about. So question that I got before giving this talk was, is there any evidence for MIPS technology? And some people very reasonably might be wondering, what the heck is MIPS? So we're going to talk about this study first because they have a great explanation for what MIPS is, and I'm just going to read it verbatim. MIPS helmets employ helmet liner technology intended to reduce rotational force to the head. This low friction layer placed between the padding and the energy absorbing layer allows movement in multiple directions upon angled impacts. The multi-directional movement is intended to disperse rotational force. And you can certainly read through that again, but essentially for a long time, it's been thought that helmets decrease skull trauma and maybe some traumatic brain injury if there is a direct impact, but not for any type of rotational impact or acceleration, deceleration mechanism, of course. And so the MIPS technology is supposed to be a way to manage that and be more like real world in terms of most trauma is not a single direct impact. It's usually like the body moving in multiple directions, essentially, or there's multiple different kinetics. Okay, and so for this study, this is the dummy that they had used. This was my favorite study that I had seen for, I think, pretty much all of the studies that I reviewed. And the reason I liked it is because they actually have a dummy with a chest attached. And then you can see here, I also love that they have these great pictures, but they put this dummy down a ramp. And then at the bottom of the ramp, it was launched over this table into sand. And the authors of this study actually also thought about how deep most sand footing is. And so they said, I think about 60 millimeters, which they felt was similar to most arenas. I don't know what they had for a base underneath that, but still I thought like overall pretty clever. And essentially, bottom line was that there was no difference in MIPS 1, MIPS 2, or the more traditional helmet technology, which they call EPF, and I can't remember what that stands for. I'm sorry. I don't know the difference between MIPS 1 and MIPS 2. I'm sorry, and I didn't have a chance to look into that. I don't know if anyone else on the group can comment on that, but for this study, no difference. I would say maybe not something to focus too much on. The limitations, obviously, this is just a model, so it's not real world data. And I think probably it'll be a while before we have real world data. And then they also, for all the studies that I saw, it was all done at fairly slow speed. So this one was done at about 350 meters per minute. So for cross-country speeds, for example, I would say maybe not so relevant. But anyways, that's what they found. Okay, and then I think every so often, especially on social media and the internet, there'll be these helmet ratings where it seems so convincing and compelling that one helmet is significantly better than another one. And so eventually I did find their protocol for the STAR evaluation system and took a look at how they decided which helmet was better than another one. And so they do have some MIPS helmets here. So I guess actually looking at this, the top 3 are all MIPS helmets. And what they did for their study is they've got this stationary human and helmet here, and then this pendulum that swings and hits the helmet. And they say that they were able to assess both rotational force and direct impact. I personally just don't see how it could really assess rotational force that much. It just like it's such a static type of design that it doesn't seem totally like a fall to me. And then we also don't have the complicating factor about the torso and how neck movement and body movement are going to affect the fall and the impact with the head. So I would say I like this setup a little bit less than the last one, but I also recognize that it's probably very hard to study these things. And then so they also have data sensors on the inside of this dummy human head. And it sounds like it's at the center of gravity, which I also think would be, again, like a very reasonable way to test for a study. But it's not totally real world because the brain, of course, is just underneath the skull. It's not like the brain is just at the center of gravity. And so I don't know if there would be a difference in impact as well from like the outside of the brain towards more of the center. I'm not sure. Sorry, I'm just looking at my notes here. And then I think the last thing, again, speed was slow. So this one was 378 meters per minute for the maximum that they use this pendulum for. And then their statistics, like their calculations from a math perspective, were very confusing. And obviously it's not my first time reading papers. I found it very difficult to understand. And then when it's difficult to understand, it's hard for me to really appreciate what the difference would be from a clinical perspective. So let's say there's a tiny difference in measurement of acceleration or velocity within this like brain, we'll call it. Does that translate to decreased traumatic brain injuries or concussions or bleeds? And I would say really not known from this. Yeah, so I think these grading systems can be thought-provoking and may provide some guidance, but I don't know if I would consider it the be-all end-all. And then this is an article about bicycle helmets. And we'll just pull up. So this is again looking at MIPS technology on bike helmets. And for, this is direct impact, and the red line is the non-MIPS helmet, and the blue line are the MIPS helmets. And then they've got like hair, no hair, stocking thing, which I thought was all useful and worthwhile to consider. And so here, really no difference between MIPS and no MIPS for direct impact. And then for these graphs, this was angular velocity and acceleration, and they do see a decrease with the MIPS helmets. So I would say different from the first one that we had seen. And I have, I guess, a couple thoughts on why the MIPS have been shown to be helpful in this study. So when it's a bicycle helmet, it obviously has a totally different shape to an equestrian helmet, and it does have like more vents in it. It comes down a different, like different length. And then hair versus hairnet, I think that would be hard to predict. And there's probably some impact from what type of hair people have as well, which again, just has not been studied, or at least I haven't seen anything about that. And then the MIPS in the study, I think again, it was like the helmet was either, I think it was dropped, if I remember correctly. It wasn't like the initial study where they had launched an entire mannequin or dummy. And so that could be part of the reason why there's a difference. And again, I kind of wonder, what is the clinical significance? So if we have statistical significance, that might mean that mathematically, we don't think that there are differences due to chance, but clinically, does this matter? Like, does this decrease the risk of going to ICU, brain bleeds, those kind of things? And I would say that's not known. Okay. And then I did just want to bring this up. I thought this was a really interesting study. And if anyone has teenage, or especially teenagers, but tween or younger children, this is probably worthwhile knowing about. So if someone has a concussion, as we had talked about before, the recommendations are really to rest for 48 hours following that event. And it does look like there is a significant benefit to not being on your phone constantly during that time. It doesn't have to be no screen time, but we really do say limited. In the no screen time group, we sometimes see increasing anxiety or frustration. I could see that leading to fights, which is probably also not going to help concussive symptoms, but limiting it to like a couple minutes at a time, and then going back to resting or taking your eyes away from the screen. The difference was quite significant. So in the people that were not using phones, either hardly at all or not at all, their recovery time was about 3.5 days. And then in the people that just used their phones as they felt, it was 8 days. So for anyone that's had a concussion before, or even a headache, 3.5 headache, I would say is significantly, 3.5 day headache is significantly better than an 8-day headache. So my thought would be to try to limit screen time for sure. There are some limitations with this study as well, in that it's a pretty small cohort and symptoms were self-reported. And at the end of the day, everyone had to complete a self-reporting screen on their symptoms and how much they use their cell phones. And so there certainly could be some inaccuracies, but just with how big that difference is, like double the time to recover, I feel like there's probably something there. So my takeaway for helmets for sure would be, I think that wearing a helmet is wise and intuitive. And then I think probably looking at the MIPS technology, either we don't have enough information for me to really feel strongly that it's the way to go. So I think a proper fit, not damaged, and not too old is likely more important than like a 2024, 2025 model. And if you're wondering, when do helmets break down? I don't know. I didn't see any studies about that. Maybe that can be a future talk. And then I do have a mildly inappropriate joke, but I'm hoping that this will help everyone remember to wear a helmet. So I feel like condoms, helmets have to be used every time and for the entire duration of the ride to be effective. And Yoda is encouraging you. And then I just wanted to talk briefly too about age. So there's kind of two things to think about with concussions and age. These are two CT scans, and the one on my left, hopefully your left as well, is a normal CT scan. So you can see that the brain fills up the entire skull, like around the outside. That looks fine. And on the right, there is all of these black spots kind of scattered throughout the brain. And as we age, it is normal for us to lose brain mass. And what that means is that if we have a head trauma, then it is more likely that there will be more movement of the brain in the skull and more risk of bleeding. And so if you are coaching, for example, or riding with friends, let's say, that are older, I would have a lower threshold to go and be assessed by a doctor in an emergency department. And this is just to show our guidelines in the emergency department. So for anyone age 65 or older, they get a CAT scan if they've had really any kind of fall. Otherwise, recurrent vomiting would be worrisome. And most of the stuff I'd say that we've either already covered or it's probably beyond the scope of this talk. But that was the one thing I did want to point out, is that age matters. And then for kids, the only other thing is their head is larger in proportion to the rest of their body. And so we can see different types of neck injuries, but we still, like, it'd be the same thing where you still really want to try to maintain stabilization of the head and neck and keep it in a neutral position in relation to the torso. Okay, now we're going to talk about air vests, because I too like to live dangerously. Not because I don't have one, but just because I feel like this is going to be a hot topic and controversial. Okay, this is the best study that I could find. So we'll start off with best first. And this was a study that looked at competitions from 2015. Was there a question? Okay. So FEI sanctioned competitions from 2015 to 2017, and then looked at incident reports. So there were 60,883 rider starts and 3,305 falls. So like pretty good number for, especially for an equestrian study, honestly. And the data was worse with air vests. And there's a couple thoughts as to why, but so you can see here that they break everything down into percentages as well as year. And so for the people wearing an air jacket, let's say just looking at serious and fatal injuries, the percentages are consistently higher for those wearing an air jacket versus no air jacket, which is not super intuitive. And the authors in this study had wondered if possibly this was related to the ripcord, or like the cord that actually causes it to inflate. And they wondered if maybe that would change the trajectory of the fall and make it a more high risk fall, or possibly affecting how a rider can tuck and roll. And then possibly also a startle response from either the horse or the human on the way down, essentially, that results in changes to how they fall. But certainly interesting. And then the only other study that I could find was a Swiss study from 2016, and it looks like they didn't study any of the ASTM or beta vests. It was just, it looks like pretty old school regular padded vests, and then they used a mannequin. So this is not like retrospective data looking at real world data. This is in a lab again. And so they put these sensors on the mannequin and then put a shirt over top to make it more real world, and then strapped the vest on top of that. And then again, like in a lab situation, not as good, I would say. They just dropped a 2.5 kilogram weight onto the vest. And then the other thing too, like 2.5 kilograms, I think if we're falling, it's a lot more than 2.5 kilograms for weight and force. So I feel like I can't really draw any conclusions from this study personally. And their results were that the air vest combined with a padded vest was superior to either an air vest or padded vest alone. And there was maybe some signal of an air vest being better than a padded vest. But again, this was like the old school vests, and I would say not real world data. And then this one isn't a great study, so I think we'll skip that one. And then kind of, I'm coming towards the end of my presentation now. So I had just going through some of the questions that I got on the Google Drive before starting this talk. And one of the questions that came up was if a parent or an athlete is refusing care. And for competitions, the quote that I could see from Equine Canada was, "The competitor is solely responsible for ensuring the on-site medical assessment takes place." And I do think that whether you are a coach or a healthcare provider or a friend, like ultimately the other person is responsible for making their own decisions. And so if a person is able to appreciate the risk of carrying on riding, and they don't seem so altered or confused that they're not able to make an informed decision, then I'm not sure if there's too much that you can do. Like, people are allowed to make bad decisions. The only thing I think that you could do as a coach would be to refuse to continue coaching them at that moment until they saw a medical professional. And I am certainly happy to hear from other individuals online, or especially other coaches, what they might do. But yeah, obviously a very uncomfortable situation for sure. And then one of the other questions that I got was about how best to, I don't know about how best to fall off, but how best to maybe train to fall off, or the best exercises. And a physiotherapist might be better equipped to answer that. I would say that I'm probably better at dealing with the aftermath of falling off and not so much preventing it. Intuitively, I would say that trying to maintain some degree of fitness would be important, and then also flexibility, core strength, all of those kind of things. And so, however one does that, but just like we don't expect our horses to go from the pasture to running an event, I think we have to have the same forgiveness to our own bodies. And then with that comment about physiotherapists can be super helpful if you are having any symptoms after a fall in terms of like stiffness or certainly concussive symptoms. There is, like in Red Deer, for example, there's concussion specific clinics, and definitely in Calgary and Edmonton as well. I think rural areas, it depends a little bit, but that can certainly speed up recovery. Oh yeah, and then I also got a question about backcountry and rural or mountain emergencies, and I have to wonder if that question came from Lori. And I just felt like I wasn't sure how long this talk would go on for, and I felt like it would maybe be too much to try to cover some of that in this talk, but I would be happy to come back again if everyone felt this was helpful. And then future topics I thought could be splinting, tourniquets, or heat and cold emergencies. I sometimes hear some funny things at competitions like, oh, I'll just give my child more water. And it's like, well, that only goes so far. And then refusal of care, which is more of an ethics talk, I think. And again, I'd be looking for help from some colleagues for sure. And then references to all the studies that we went over. Thanks for bearing with me. And then this last link is definitely worthwhile watching and goes back to the very start of the talk when we were talking about essentially a collapsed rider. And I think it's common for people to think that if there is any type of breathing or if eyes are open, the person is probably alive. And this video does show death, honestly, in different sports where competitors have collapsed on the field. But it demonstrates that we can still see some weird seizure type movement or some breathing that looks like the person is alive, but you really have to like check for a pulse. And if it's not normal breathing, then CPR should be started and someone should get an AED. And again, I'll leave that up to you if you want to watch that. Okay, questions? Okay, I'm just reading some of the things in the chat. Someone said, can I also add that anyone who has hit their head should sit out for the rest of the event? And I 100% agree. Again, I guess unless they have, unless it was like an unclear if they hit their head, like sometimes when people fall on their back, for example, and if they have no symptoms, like no amnesia, nothing like that, then maybe I think could be considered, but they should definitely see a healthcare provider before carrying on and be able to talk about whiplash with a concussion. So I would say that for whiplash with a concussion, harder to kind of be able to see, but it would be the same sort of thing. So I think what I could see happening for eventing quite commonly, or any type of jumping, would be if a horse stops and then someone's head and neck goes like forward and then backwards, and maybe they stay on the horse. So there's no direct trauma, but certainly that would be high risk for concussion. I don't know if you have specific questions, Lisa, about whiplash. Okay. I did also, that just jogged my memory, for the initial concussion assessment. Like if I was assessing someone for a concussion at an event, lots of times the sport ones will say stuff like, what team were we playing, or what inning were we in, that kind of thing, which doesn't really apply to eventing. And so if I was to assess someone, I would say things like, what number are you? Or what jump or what combination jump do you have after the one that you fell off at? Because would all be things that a rider should know. Or what was your ride time for this event? How many times have you competed at this level? And then if it's a clinic, you could ask them like what the course was prior to the fall, or what time were they scheduled to start riding, who had ridden before them, all of those kind of things. Because again, they should remember all of that if they don't have a concussion. And I'll send just my slides, and I have written some of those down in the presenter notes. So if you're trying to remember what I had said there, then that's what I would use.
Perfect. And if you can send all of the extra links to us, that would be great.
Yeah, you bet.
Have you ever had a concussion or trauma, something in your life riding that you would like to share?
Me personally?
Yeah, like a fall or something that, yeah.
Yeah, I don't think fortunately, knock on wood, my God, I didn't have falls for quite a few years, and recently I've fallen off so many times. I don't think I've had a concussion from riding, but I certainly did snowboarding once, and it was awful. I had like vague, hazy memories about what had happened, and I felt like garbage for a very long time.
I also had a bad snowboarding fall, so I feel you there.
I don't know why I try.
Oh, Tony has a question. She said, "Can you clarify in that first air vest study, were the air vests worn by people in higher levels and that would contribute to the more severe injuries, or was it due to the vest?"
Yeah, good question. So because it was all FEI competitions over those 3 years, that had been my thought as well. Like, is this a level thing where more people at higher levels with higher risk are wearing air vests? But it doesn't look like it, because it sounds like air vests and injuries were kind of spread out across the different FEI levels. And I mean, FEI levels in general are higher levels of eventing and probably higher risk. So I don't think it's related to level in this case.
Perfect. Lisa, you had your hand up?
Yeah, I was just going to talk. Can you hear me?
Yes.
Okay. The typing is hard on my. I was just going to ask a question, and I know you had said that when you get older, you get concussions. Or I'm a little confused as if it's easier or not, but is it the more, I was told the more concussions you have, the easier it is to get another concussion. Is that true?
Yes.
Okay.
Yeah. Yeah, good question. And I would say I didn't see that specifically in guidelines, just that repeated concussions are more likely to lead to really devastating consequences. And the age, I would say, not so much like the over 65, not so much related to concussions specifically, but more severe brain injury, actually, like bleeds in the brain and that kind of thing. And then certainly I would say that in the acute period after a concussion, so let's say in the first month or so, or if you have any lingering symptoms, it is definitely easier to get a concussion during that time period. Like a smaller insult can cause a concussion. So I don't know, like if you've had one concussion, let's say when you're 16, and then another concussion when you're 30, if there would be a significant difference between your ease of getting a concussion compared to someone that didn't have a concussion in the past. And let's say like both of those individuals are now 50, I think it would probably be pretty similar. But if you had a concussion 2 weeks ago and your friend did not, you are more likely to get a concussion, certainly. Does that make sense? Kind of.
Yes. Thank you very much.
I know that I had a really bad concussion, and the next day I went out and jumped a 3-6 course in college, and that was not good. And it's not like and it wasn't like I got another concussion, but just like the concussion of me doing that. The next day I had to be up for a really important meeting, and I slept through everything, and yeah, my brain definitely did not. Yeah, it didn't. It was not good. Yeah. So
Yeah,
yeah, it makes a difference. Yeah, it's important.
yeah, and I'm certainly glad that you seem okay now, Jess, but that obviously like would be very high risk.
Yeah, no. Yeah, it all adds up for sure. Oh, Jolynn has her hand raised.
Sure, go ahead, Jill.
Yes. Hello. I feel like I've heard in the past that if someone has a concussion, they shouldn't go to sleep, or that you should wake them up every so often. Is that true, or how do you handle sleep?
Yes. Oh, I'm so glad I forgot to include that. So that was the old teaching that is no longer current teaching. And so when people want to sleep, let them sleep. Absolutely. Because again, that's part of that first 48 hours of brain rest.
Good to know. Thank you.
If anybody else has any questions or anything, feel free to pop on or put them in chat. Or we could start to wrap things up. Does anybody have any like personal things they'd like to ask about? Concussion or otherwise? I know there's lots of like random things that happen and we have questions or we don't know really what happened or what could have happened.
I could just have one more quick question about, do you have a opinion or just a talk about the concussion syndrome?
I don't have a specific talk about it. Like, do you mean in terms of if a person's not recovering at a normal rate?
Yeah, what makes it turn into that, or is there a time frame, or is it just like, is it a time frame, or is it like more symptoms?
More symptoms, but past a month, we do start wondering about post-concussive syndrome. And then it really can be a lot of different symptoms, like headache, of course, would be one that we often think about, or vestibular issues. So feeling off balance, or poor depth perception. And I think that's really where a physiotherapist can be super helpful in terms of trying to get you back on the right track. But we can't even see things like seizures sometimes, and it, like, there's no evidence for giving someone anti-seizure medications following a concussion to prevent it, nothing like that. It just there are risk factors for developing it. Like, if you've had concussions in the past, you are more likely to get post-concussive syndrome. Or if you're female, honestly, and if you have a history of headaches or migraines, then all of those things make it more likely for you to have a prolonged, slower course.
Okay, thank you so much.
I'm very aware of that because I have a lot of those risk factors.
Okay, any other questions?
And then one other thing that I had just thought about, I think sometimes there's also kind of older school teaching that we shouldn't give people pain medication for concussions or whiplash injuries because it might mask symptoms. That is also not really true. Goes for pretty much everything in medicine. Like Tylenol and Advil is almost always safe. We worry more about Advil, naproxen, all of those NSAIDs as people get older, but in younger middle-aged people, Tylenol or Advil is fine and maybe speeds recovery from a concussion.
That's awesome information, Alanna. Thank you. Lisa, do you have any other questions? Like, how are you doing? Are you back riding and things? Sorry to put you on the spot, but like,
No,
yeah.
it's actually funny. So I'm in July, I'm going on 2 years of a concussion. And I have been like down this awful long road. So I am riding again. I do like, I'll start riding and then I have to take a month off and then I start again. Unfortunately, I am in a very rural area, so getting proper help has been quite difficult. But yeah, I'm slowly getting there. No, this was very informative, so I was glad to see this. And it's good to learn on any sort of yeah, it's good to learn any sort of information on this. So
Thanks for sharing your story, Lisa.
yeah.
Right. Any other questions?
You're welcome, Tanya.
Right. So I guess if there's nothing else, we will. Thanks, Leona. I miss you.
Yeah.
All right. If there's no other questions, I guess we will wrap this up. Thank you everybody for joining us, and for the HTA and Kathleen for arranging this, and Alanna for sharing all of your presentation and your insights, and everybody who asked questions. Yeah.
Yeah, thanks for coming, everyone. I hope that it's helpful. I'm
Yeah.
sure, I hope that I'll see some of you around this summer.
Yes, we will. Thank you to everybody in the chat who's thanking us. All right, we will see you guys another time. Thank you so much. Thank you, Alanna. Bye-bye.
Bye.